Good morning and welcome. It is my honor to introduce all of our speakers this morning. First, we have Kyle Bernstein, as pictured here and soon to be live behind this podium. Kyle is currently the Chief of Epidemiology, Research and Surveillance for the STD Prevention and Control Services section of the San Francisco Department of Public Health. He received a BA in Community Health from Brown University and a master's and doctorate in Epidemiology from Johns Hopkins Bloomberg School of Public Health. He has worked as an epidemiologist for the California Department of Public Health, the Baltimore City Department of Public Health, and the New York City Department of Health and Mental Hygiene. This morning, Dr. Bernstein will provide an overview of the epidemiology of STDs in San Francisco.
Is this on? There's nothing like seeing a big picture of yourself on a screen before 9 in the morning. So thank you, Trang. As Trang has mentioned, I'm going to be talking today, giving a brief overview on the epidemiology of STDs in San Francisco. And hopefully there'll be some time for questions at the end, but if not, I'm here for the remainder of the morning, so please feel free to jump up and grab me. As well, here's my email, which is probably the best way to get in touch with me, so if you have questions or there are data requests, please feel free to contact me. Before I get started, I wanted to just mention that there's a variety of ways to stay up to date with what's going on with respect to STDs in San Francisco. I think that the program's really done a fantastic job of organizing a lot of our materials on our website, which is sfcityclinic.org. If you go on that website and click for providers, you can get access to our monthly STD reports, our annual report, and this year we've started doing some population-specific surveillance supplements. So we have an MSM-specific supplement and an adolescent supplement, and those are all online. They're PowerPoints, so please feel free to use those slides and presentations that you have. Just make sure that you give credit where credit is due. So here is a summary of the 3 primary reportable STDs that we focus on in the STD program from 2007 through 2011. And I'll just orient you to this slide a little bit because this axis represents the rates of chlamydia and gonorrhea, and this axis represents the rates of syphilis. As you can see over time, chlamydia, gonorrhea, and syphilis have all been increasing. When we look at our projected rates for 2012, we see continual increases. And unfortunately, this is a story that we've told before. So I'm going to go into a little bit more detail in a second, but just to give you a sense of the magnitude of these case reports. This is first half of 2011 compared to first half of 2012. So in the first half of 2011, there were 2,288 chlamydia cases reported, compared to 2,412 in 2012. That represents 124 extra cases, or a 5.4% increase. So as you see throughout this slide that we've had increases in rectal chlamydia, overall gonorrhea. Our rectal gonorrhea has increased fairly substantially, as well as syphilis. When we look at specific populations, it's when we start to see some of the better news. We've had a very slight increase in adolescent chlamydia, unfortunately a much larger increase in adolescent gonorrhea. And then our MSM chlamydia and gonorrhea have also gone up. Again, these are projections. We won't have final 2012 numbers until midway through 2013 because it takes us a little while to process all that data and get late reports. So as I mentioned, we have 2 primary populations in San Francisco, adolescent males and females, and then men who have sex with men. These are rates of disease for adolescents and then for adults, and adults here are defined as folks 26 and over, for chlamydia and gonorrhea. So the adolescent rate for gonorrhea in 2011 was 249.4 per 100,000, and for chlamydia was 1,024.76. Compared to the rates in adults, we see that the rates in adults for gonorrhea is a little bit higher than adolescents, and I'll talk a little bit more about this. This is largely a result of MSM. But if we look at our chlamydia rates, the rates among adolescents are significantly higher than what we see among adults. Looking at this data a different way, for adolescents, we estimate that in 2011, 1 out of every 401 was infected with gonorrhea, and 1 out of every 98 was infected with chlamydia. We compare that to what we see with adults, which was 1 out of 348 was infected with gonorrhea, and 1 out of 228 infected with chlamydia. So here's one of the bright points in this presentation, is one of the successes that we've had. This is the rates of chlamydia in San Francisco stratified by less than 26 and over 26. And you can see that first the rates in the younger group are significantly higher, but we see a little bit of a dip here, which we're optimistic will continue throughout the future. Unfortunately, we continue to see increases in adult chlamydia, and I'll talk a little bit more about this, but as I mentioned, we suspect that a lot of this is driven by MSM disease. This is a graph that shows the distribution of adolescent chlamydia by smaller age categories. So the blue bars are less than 14, the red bars are 15 to 19-year-olds, and the green slashy bars are 20 to 25. You can see that very young adolescents really don't contribute a huge amount of morbidity. The middle age group, 15 to 19, is the sort of second place finisher. But the bulk of our disease is in 20 to 25-year-olds. Switching gears a little bit, so this is gonorrhea. It's the same graph, so the red lines are under 26. The blue lines are 26 and over. In between 2010 and 2011, we've had zero change in adolescent gonorrhea. We've had a pretty dramatic increase in adult gonorrhea. This is the same graph for gonorrhea with our ages, 14, 15 to 19, and 20 to 25. We see a very similar picture. So adolescents are disproportionately affected, particularly older adolescents, 20 to 25, which makes sense because those are the ones that are probably most likely to be sexually active. So what are our recommendations, just as a reminder? Who should we be testing for chlamydia and gonorrhea? We want to make sure that we test all sexually active women less than or equal to 25 years of age, any woman who is pregnant, regardless of their age, at the first and third trimester. And this is really important, regardless of intention to complete pregnancy. So if you have a patient who conveys to you that they're probably going to terminate their pregnancy, you should still test them. At IUD insertion, I know this is sort of a controversial topic and everyone always has 100 questions for me, and then I defer them to Susan and Stephanie because I'm not a clinician. We also strongly recommend that everyone diagnosed with chlamydia and gonorrhea be rescreened at 3 months. The rates of reinfection are very high, and we know that the risk of complications related to fertility increase the more times you are infected with chlamydia and gonorrhea. And then, of course, diagnostic testing. So we define diagnostic testing as folks who are coming in that are symptomatic. They complain of discharge, dysuria, pelvic inflammatory disease, or if they come in and they say, my boyfriend or girlfriend told me they had chlamydia and I need to get tested. There's a few reasons why we don't recommend screening for chlamydia in low prevalence populations. And when we talk about low prevalence populations, those are what we refer to as adults or older women. And in the STD world, older women is 26 and over. It's a kid's game in the STD world. There's a couple of things. One, it's not really cost effective. There's been a few studies that have been done, notably one from CDC that showed that if the prevalence of disease is below 3% in females, that screening is not cost effective. And it's estimated that it's about 2% in gonorrhea. But I think more importantly, that when you screen, even with a very good test in a low prevalence population, you have a very low positive predictive value, which is sort of a fancy term for a high number of false positives. So I'm going to go through an example, and I think folks who have been here before may have seen this, but I really like it, so you're going to have to hear it again. These are two scenarios where we're using a test for chlamydia that has a very high sensitivity of 95% and a very high specificity of 99%. In this top scenario, it's a high prevalence population. 6% of the folks are infected with chlamydia. In this bottom scenario, it's a low prevalence, 1%. So in both scenarios, we're going to test 1,000 people. So in this high prevalence group, we test 1,000 people. 60 of them have chlamydia, and the test says that 57 of them have chlamydia. So it's a very decently good test. We only get 9 false positives, where the test says that they have chlamydia, but they actually don't. So there's 9 false positives. The positive predictive value is basically Overall in this population, our test said that there were 66 people who had chlamydia, but really only 57 of them truly had chlamydia, which means that the false positivity rate is only 14%. So as a clinician, what this means is when you test in a high prevalence population and the test comes back and it says that the person has chlamydia, there's a very high probability that they actually have chlamydia and that it's not a false positive. When we look at this low prevalence scenario, 1%, we only have 10 people who actually have chlamydia. But the test is going to say that 20 people have chlamydia. What this means is that 50% of the people that the test says has chlamydia actually don't have chlamydia. So I think this is an important implication considering what a chlamydia diagnosis could mean for somebody in terms of the relationship with their partner, their spouse, allegations of infidelity. There's lots of complications here. So we want to try and identify as many people as we can who actually have disease, but we want to minimize the impact of these false positives. And we can do that by focusing our testing in these high prevalence populations. What does SFDPH recommend in terms of syphilis screening for adolescents? We do not recommend syphilis screening for adolescents unless your patient is an MSM or a transgender male or female. So regardless of age, MSM, it should actually say MSM trans, should be screened every 3 to 6 months. But heterosexual adolescents, we do not recommend screening. So now we're going to switch gears and talk a bit about our MSM in San Francisco. We're very fortunate here because of the great work of folks in the HIV prevention section who have come up with population estimates as to how many MSM live in San Francisco, and that's estimated to be about 65,000. So as a result, we're able to calculate rates of disease by MSM and heterosexual males. And what we see is that these are the rates for MSM. Syphilis, 975 compared to 6.4 for heterosexual males. Gonorrhea, 2,436 compared to 124 for heterosexual males. Chlamydia, 2,452 compared to 325.4 for heterosexual males. So what I hope you see here is that MSM are disproportionately affected by STDs to a large magnitude, similar to what we saw with adolescents, although magnitude here is probably a bit larger. This is the same presentation as earlier, sort of flipping things around. For MSM, we estimate that about every 1 out of 103 who are San Francisco residents was infected with early syphilis in 2011. 1 out of 41 was infected with gonorrhea, and 1 out of 41 was infected with chlamydia. If we compare this to heterosexual men, 1 out of every 15,624 was infected with early syphilis, 1 out of 803 with gonorrhea, and 1 out of 307 with chlamydia. So again, you can see that MSM are disproportionately affected. So this is a graph of our early syphilis rates, and I promise you that there are actually lines down here, but because the rates of disease are so high among MSM, who are those in the red, that you don't even see the females and other men. In San Francisco, approximately 97% of our disease is among men, and over 90% are among MSM. So we have a very small epidemic among heterosexuals here. If we look at our MSM early syphilis by HIV status, and the axis here is the number of cases, you can see that the majority of cases are among HIV-infected persons. The blue line is HIV negative, and then this green line is unknown status. Since the epidemic among MSM has begun in about 2000, 2001, every year about 60% of our syphilis cases are HIV infected, meaning they know they're HIV infected. They're not new diagnoses of HIV. So it's very important to encourage your HIV infected clients to make sure that they get screened routinely when they go in for HIV care. We've been doing a lot of work trying to reach out to HIV providers to ensure when a patient comes in for their CD4 viral load that you ensure that they get a syphilis test as well as chlamydia and gonorrhea. Speaking of chlamydia, here are our chlamydia rates. So the blue line here is MSM, the red line is other men, which was really heterosexuals, and then the green line is females. Again, you can see that MSM, the absolute number, these are the rates. The rates of disease are highest among MSM and look to be increasing. These are the gonorrhea rates. The blue line again is MSM. It looks like things were sort of static for a while and we've seen increases. and the magnitude of disease is much higher than we see for females and other men. This is a graph that looks at the number of reported cases of blue is rectal CT, the red is rectal GC, the green is pharyngeal CT, and the purple is pharyngeal GC. So a couple things to note here. One is that there's very low rates of pharyngeal chlamydia. We don't think that the throat is really a place that chlamydia likes to live. That being said, we still do identify cases. The amount of rectal chlamydia, however, has been going up, not exponentially, but there's been large increases. Again, it's important to consider that pharyngeal and rectal infections are almost exclusively asymptomatic. So going in and saying, well, I don't feel like there's any problem with my rectum, does not necessarily mean that they're not infected there. As a result, SFDPH recommends for MSM and transgender patients that all sexually active MSM and trans folks get screened for rectal and pharyngeal chlamydia and gonorrhea and syphilis every 3 to 6 months. Please note, we do not recommend urethral or urine screening for this population because, as I mentioned, a lot of those guys who are infected urogenitally are also infected at their throat or their rectum, and there's a lot of guys who are not infected urogenitally who are infected at other sites. And we've done a couple of, I think, really interesting analyses, and I'm happy to share it with folks. Contact me, I'll send you the papers, that look at the proportion of missed disease that we would have gotten if we would have only screened at urogenital sites. And it's over 90% of the disease would be missed. So it's a huge amount of disease that's going on that does not infect it at urogenital sites. Again, if somebody comes in and their penis hurts or they have discharge, you should test them there. We're talking purely about screening. No screening at urogenital sites, diagnostic testing. And then again, we want you to encourage your patients to come back every 3 months or at 3 months to be rescreened because the rates of reinfection are very high. So that's all I have. And I want to make sure to acknowledge the great folks that I work with, Bob Cohn, Sally Stevens, Trang, and Hannah, who work in the epidemiology unit. Of course, Amira, who is the grand dame of the annual STD update. And then Stephanie Cohen and Susan Phillip, who are always hugely helpful in us figuring out what's the best way to approach and answer some of the questions that we're looking at here. And if there's any questions or there's any way that we can help you, please don't hesitate to contact us, because we really feel that we're a service organization and we're really here to help you all do as good of a job as you can. Thanks.